Thank you very much for the introduction, and thank you for the invitation. It's a great pleasure to be here. As Charlie has introduced, I'm going to demonstrate some issues relating to histotripsy. So I'm going to tell you what is histotripsy and the mechanism of histotripsy, and present you with some evidence which is limited at this stage, and also the future application of histotripsy. It took about more than 20 years for the development of this technology. It was conceived back in University of Michigan, and there are a lot of in vivo and ex vivo studies accumulating to the FDA approval of this technology back in 2023. You might have heard about high-intensity focused ultrasound, or high-field for abbreviation. There is a distinct difference between the two. For high-field, usually the ultrasound wave will be low amplitude. They tend to be continuous, as you can see from this graph here. And they affect thermal energy, which means there's heat involved, and there is also quite a wide zone of treatment zone. For histotripsy, the amplitude is very high and high pressure, and each amplitude is also very short interval, microseconds. It results in mechanical tissue destruction and causing what we call acoustic cavitation, meaning there is a cavity or hole left in situ after the treatment. The effect is very precise, hence the point effect. This is the three components of histotripsy system. It consists of an ultrasound system, which you all will be familiar with, and the actual histotripsy system itself, which incorporates the console plus this treatment head, which is the actual ultrasound treatment head for the treatment. And once the voltage is applied, the ultrasound wave will be generated, and which will focus on this pinpoint area here across the liver. And the whole system here is submerged into a water bath. As you know, when you go for your ultrasound scan, we apply jelly on top of the probe to avoid any air trapping in between the probe and the skin, because ultrasound doesn't traverse very well across the air. So in order to avoid that, we submerge the whole thing into the water, and the water needs to be degassed, i.e. there is no air molecules in the water. And to do that, you need a third component here. So before we do the procedure, we pour in the water, and this particular system here will get rid of all the air molecules so that we can transfer that to the water bath. So here's the schematic representation. That's a membrane that will be placed here in a water bath, which you oppose to the patient, and the treatment head here, and the supporting mechanism around it. Hence, we need to do a pre-assessment to make sure that this little bit bulky treatment head here will be able to angle accordingly in order to target the ultrasound to the tumors. And this is just a, I'm not sure it works. Oh yeah, that's the video here. So essentially, we apply the voltage, and it is a kind of a focus phenomenon. This is the micro bubbles here that is produced. Currently, it's 4 by 4 by 8 millimeter. These micro bubbles here will cause cavitation. It will move around the treatment zone that's required for the treatment. And it is precise. This is by University of Michigan. They created this treatment zone here, which you can create the margin precisely according to the area of intent. As I mentioned, it is a computational system, so when you apply the energy, there will be microbubbles formation here, which will move around. You'll see the schematic diagram here. The green area there has been treated, and then these microbubbles will move around within the treatment zone, and the orange bit is the active zone that's being treated. And you will hear the sound during the treatment. This is the hissing sound for the cavitation, and this will be present throughout the procedure. So the histotripsy system is manufactured by Histosonics or Edison system. It was approved by the FDA back in December 2023. It was fast-tracked to the UK by the Department of Health via the Innovative Devices Accelerated Pathway. The MHRA has temporarily approved it under the unmet need clinical authorization back in spring last year for the use in primary and secondary liver cancer. It is yet to be commissioned and it is yet to be evaluated by NICE. We were lucky in Cambridge. We received a donation from the Lee Cushing Foundations and our charity trust. And we began our first treatment for the NHS patient outside the clinical trial back in mid-October last year. I will show you these videos here for the treatment. So patient will be asleep under general anesthesia, and during the procedure, we'll perform an ultrasound scan. For example, this is a tumor here. We just need to make sure we can still see the lesion or the tumor just before the treatment. And this is the robotic arm, which is attached to the system. We apply canola oil here, again, to avoid any air trapping between the skin and the water bath. And you apply the membrane, which will be turned around to the, on the skin. And then we bring this close to the patient on top of the liver, obviously. And you position that accordingly, and you bring in this system here that degas the water, and you deliver the water into this water bath. We have to manage that appropriately to avoid overloading it, obviously. And once we are happy with it, we'll bring this system in, which is the treatment head here. And I can also perform ultrasound, the standard ultrasound probe in the water to make sure we can still see the lesion. And you bring this robotic arm, which is all controlled automatically in terms of the angulation. You can increase or decrease the depth. And then you will then contour the area of the treatment zone that you want to do. So for example, the orange here is a treatment area, and you will create a margin of at least 5 millimeters around it to make sure you have the appropriate margin. So you continue. The important point here is targeting, that you are able to ensure that you are able to target the tumor accordingly. So the most difficult part of the procedure is actually localization or targeting the area precisely that you want to do. So we will have to spend a little bit of time, and once you're happy with that, then you contour the system like identify the areas that you want to control. And therefore, the patient needs to be asleep, because if they move with respiratory excursion, then whatever you contour here may be misplaced, but you not be able to deliver the energy accordingly. Sorry, we were a little bit excited there. That was our first patient, and that was me pressing onto the on button here, essentially to apply voltage. And once the voltage reaches certain threshold, the ultrasound energy will be delivered, and you will hear the hissing sound as well as looking at these microbubbles formation. So that microbubbles, as I said to you, is going to move around that treatment zone. For example, if it's a 3 centimeter volume, then it will continue to treat on that area. You can see the green here has been treated. The orange is the active microbubbles, 4 by 4 by 8 millimeter. So it will move around. You can visualize it real life. And this is half of it, or almost 2/3 has been treated. And you want to be able to continue to visualize that to make sure you can stop the treatment and recontour or readjust it accordingly. So as I mentioned, this is the treatment zone here. This is your target, and you apply a margin of at least 5 millimeters around it. And it is that microbubbles that will continue to create mechanical destruction and cause the cavity. And here's the ex-bovine pig liver tissue in a phantom. And this is during the application of histotripsy. And again, this is the entire treatment zone that we want to treat. And you continue to apply the ultrasound wave until the whole area or whole target zone has been completed. And again, a schematic diagram of microbubbles formation and destruction. In the process of formating the microbubbles, the surrounding cancer cells will be mechanically disrupted and form liquid. So you will see here, the cells is disappearing, and then it will be, at the end, will be left with liquid in situ within the area of the treatment zone. And here's a phantom. This is during our demonstration. After histotripsy, embedded in it with the jelly is the liver. You will see these cells here, liver cells being liquefied, become what we call lysate without any cellular components within it. So here's the microscopic differences between the treated and untreated area. You will see on the red margin here, only some red cells here remaining, whereas the untreated here will be, they will see some liver cells still remains. And there is some selectivity with histotripsy treatment. Essentially, it preferentially, or the protein or extracellular protein is not really sensitive to this particular intervention, and therefore bile ducts or vascular structure will be preserved. And therefore, it is actually quite suitable for tumors where they are located in proximity to major blood vessels or major bile ducts. The selectivity is quite stark in terms of what sort of size of vessels are less sensitive. So for example, any vessel which is more than 300 microns, and the treated one is a lighter shade of gray, and this untreated one is a darker shade of gray. And you will see after 300 microns, most of the vessels are preserved. But below that, some small vessels will be destroyed. And for that reason, I think, most of the times, is this, like more than 300 microns will be more important than small little tiny vessels. I'm going to present or share some study, which is a little bit limited because of the new technology. This is a first-in-man study or three-star study conducted in Barcelona, looking at 8 patients. The main thing is to assess safety and also technical effectiveness. And they managed to reach their endpoints in summary, and there is no device-related adverse events. And you will see they included a patient with cholangiocarcinoma. Quite a number of patients here will have deranged liver function, but most of them return to baseline within the first couple of weeks or so. This is the ultrasound appearances. Sorry, it's a little bit small. So on this side here, the brighter here is a contrast-enhanced ultrasound, and the grayscale in parallel to it. So let's look at this tumor here, the bright area here, you can't see very well, but this is after the histotripsy with cavitation, and you follow up, this is at 12 weeks, they continue to involute or shrink in size. The pivotal trial is the Hope for Liver trial conducted between the USA and Europe, incorporating 44 patients, again, to assess safety and technical success. And the criteria is up to 3 tumors, less than 3 centimeters, and all the patients were ineligible or opted out for any conventional therapies. They treated smaller lesions here, but then obviously had a bigger treatment zone, and they set certain criteria in terms of endpoints for technical success and safety evaluation, and all of that were achieved. There were three major complications. Let's look at them, but you will see the first complication related to sepsis or infection in a pre-existing patient with a pre-existing bile duct stent. And that's not uncommon in anything we do in the liver. When a patient has bile duct stents, and any intervention we apply increases the risk of infection. The second patient has pleuritic or pleural lining pain, which require a couple of days of admission. And then the third patient resulted in hepatic failure, but that was because of multiple metastases from the underlying breast cancer. And other minor issues will be abdominal pain, fatigue, and pyrexia, but I'm sure those are minor that can be managed. So the complications that's been described so far, it is compatible to what we call the larger series of percutaneous ablation study or microwave ablation, which is ranged between 2% to 11%. I previously showed you the involution. So here's pre-treatment. This is the MRI scan here. This is the left lobe, the right lobe of the liver with the lesion here or the tumor here. This is after treatment. Obviously, we need to create the margin, hence it looks bigger. And this is the involution after a month of follow-up. The study has conducted a 12-month analysis, including part of it HCC and others non-HCC patients. The local control rate, initially reported 63%, was subsequently upgraded to 90%. And the reason for that was the uncertainty around the interpretation of post-histotrypsy imaging findings, because it is a new technology and it does not always equate what we know, for example, from ablation. The one-year survival is about 73% for HCC or nearly 50% for other metastatic disease, and these are comparable to other current local regional therapy for similar disease stages. Complications, we mentioned about the progression, most of it already. There was one portal vein thrombosis, but again, this is in the patient who has quite extensive liver disease. And there were 3 deaths. One is because of hepatic failure. Again, there was extensive metastasis in the liver, and you could argue that may not necessarily due to the device. And then there were 2 progression of metastases, which obviously were not related to the device. Another study, which is a real worldwide experience of 230 cases, you will see the liver is divided in multiple segments. They've treated in all segments here and in a number of different categories of cancers. The outcome were also respectable. You will see there were no complications in 95% of cases. Worldwide, there were now more than 3,000 patients have been treated, I was told. Majority of them are in the States, and some of them are in the Far East. So I told you about the complications. The one thing I want to mention is this immune activation of histotrypsy, the abscopal effect. For those who are not familiar, abscopal effect essentially means that if we apply treatment, say, to one area of the tumor here, but then there is effect or systemic effect or global effect around the entire body, causing reduction in size or improvement of the tumors away from the treatment area that you treated. It is a rare phenomenon, but it is better described in patients with histotrypsy versus other patients, for example, following ablation or radiotherapy. And this is a case. So this patient, this is the left lobe of the liver with a tumor here. You can't see very well. Post-ablation, they only treated one lesion in the left lobe. The other areas in the right has not been treated. And obviously, this patient has got multiple metastases. This is before the treatment. This is the MRI, the right lobe of the liver before. And one day after treatment, you can see For this one here, progressively, it becomes smaller if you focus on this lesion here. And then other lesions, for example, these confluent multiple lesions here, progressively also become smaller. And interestingly, the CEA enzyme, essentially to indicate the level of cancers, has also subsequently reduced after a couple of months following histotripsy. It does signify the importance of what we call immune regulation. So histotripsy ablation has certainly been described in various areas, and this is an area of research interest, and obviously to this date we are not entirely certain, but certainly there will increase in interleukins cells or panel for patients a day or two after histotripsy. If they have that increment, it means they are most likely to achieve better cavitation and hopefully better disease control. The current application for my setting, we use it in curative intent for patients who are potentially not resectable or not suitable for ablation, or who may have benefits for combination therapy, or in patients who may be waiting for transplantation. You want to make sure they don't get outside the list. You may be able to bridge the transplant. And then the second is a little bit controversial in terms of volume reduction, essentially to reduce the tumor bulk and subsequently to receive surgery, or in patients who are refractory or unfavorable to any other treatment, that we think histotripsy may offer some oncology benefit or to provide prolonged survival. There are a lot of other applications. Some of them are in research status, which I'm not going to elaborate. And certainly has also been considered to use in the brain using MRI guidance for image control. And just one last thing, histotripsy may have a role in preclinical enhancement drug delivery. So this is without the bottom panel here, without histotripsy, the top panel here with histotripsy application, 5 pulses, 50 and 100. The red bubbles here, it means that there is more drugs availability or uptake in patients or in cases that will have histotripsy treatment prior. So it does show there is an opportunity to increase drug delivery in combination with histotripsy. So in conclusion, it is a novel technology. We still do not have any long-term data. It can be used in a number of applications, but the abscopal or immune effect certainly is worth considering for combination therapy. And we are still working on the correct imaging findings, and there's still, I'm sure, a lot of research that will be conducted. My acknowledgement to the teams for the contribution to this that enable us to be the first one to have it in UK and certainly in Europe for the benefits of the patient. Thank you.